Hello, my name is Nathaniel Osgood. Within this talk, I'm going to be outlining a very exciting confluence already done between, on the one hand, system science in health, and on the other, big data and data science within the health arena. I've entitled my talk Moving Beyond Myth and Madness in reflection of a quote from epidemiologist Phil Zuckerman, passed on to me by my colleague Mark Orr, which notes that theory without data is myth, and data without theory is madness. And within this talk, in a vignette-centered fashion, I'm going to be very briefly commenting on why I believe the confluence of these two trends, the growing emergence of very high temporal density, rich longitudinal data of the sort we have emerging from a wide variety of electronic types of data collection, can provide such a key role in enabling theory-rich dynamic models. This talk is a small variant on a talk I delivered for Australian Capital Territories Health in February 2017. So within this talk, I'll first be situating the general area of discussion within the complex of increasingly complex health challenges, and talk some about characteristics of big data more generally. I'll then spend most of my time within this talk talking about a variety of vignettes. These vignettes are sufficient in number and depth that I simply do not have time to cover them all. They're also only a subset of all the work that we're doing in this area, but I hope that they will give some flavor as to the opportunities in these areas, and very particularly can give concrete understanding on some aspects of how dynamic modeling and within the system science area and big data, on the other hand, can come together. So the motivation for this work, as for so much of our work, is the reflection of the fact that the world is grappling with ever more complex health policy challenges. These challenges are many in number. Some of the most important ones are listed here. Growing syndemics of mutually interacting conditions, diabetes, for example, of gestational type, type 2 diabetes, and obesity. The interactions of substance abuse, violence, and suicide, and addictions, and HIV/AIDS, as captured by medical epidemiologist Merrill Singer in his book by that title, Syndemics. In other cases, we see the syndemics linking up areas that have often been considered in isolation, for example, infectious and chronic diseases with TB and diabetes, for example, or obesity and H1N1. At the same time, the readers and listeners will be familiar with the distressing continued prevalence and in many areas growth of mental health gaps, the increasingly high burden of mental health disorders within our populations, and gaping health disparities that are often associated with that. We're also confronting in so much of the highly developed world diseases of aging and a population that's quickly graying and has complex health needs, often comorbidities that confront it. And at the same time, since the work of Barker started to quantify it, but in a trend that's become increasingly rich in recent decades, we're aware of the pronounced effects of lifecourse impacts, the ways in which early life insults cast long shadows on the life course, whether it's chronic disease later in life, behavioral risk factors, and indeed a science of epigenetics are showing a biological grounding for how exposures can have lasting adverse impacts spanning several generations. And in many areas, we find ourselves grappling with nimble adversarial corporate actors, such as in the tobacco control space, where large tobacco companies run circles around regulators in some countries through very efficient but cynical exploitation of online forums to spread doubts about the health effects of cigarettes, to spread targeting couponing campaigns, to undercut tobacco control efforts, etc. And within our areas, we've been working on many of these topics, some of which will be featured in these talks. We note, for example, that an emergency department wait situation, while so much of the attention is on measures within the ED, we are dealing with a systemic issue. Those long lines in the ED are reflective of not just factors in the ED, but also factors both upstream and downstream. Failings in the area of home care and in long-term care facilities and informal care networks that needlessly bring individuals to emergency room for belated treatment of conditions that could have easily been headed off in their homes. And downstream, we see increasingly backups within the wards that that mean that a lot of those emergency department waits are because individuals can't get into the wards, and those individuals having time getting into the wards is because of the shortage of beds, which in many cases is due to so-called alternative levels of care patients, ALC patients, who are backed up because they can't get into community care options because of shortage within those options. So once again, something that appears in one area, in ED, is reflective of systemic dysfunction and imbalance. We know about herd immunity, and since the work of Kermick and McKendrick in the 1920s and Ross before them, there's been a growing, early appreciation for the presence of systems effects, that while individuals within a population may at an individual level retain susceptibility, one can achieve a level of herd immunity by vaccination of enough individuals, or in some cases due to past natural exposure. This can yield the population as a whole a level of herd immunity that transcends the particular status of any one individuals. And of course, in the interaction of e-cigarettes and cigarettes, there's long been debate, in many cases rancorous, concerning whether e-cigarettes are predominantly viewed as favorable in their health impacts by helping wean cigarette smokers off of a habit which exposes them to enormous harm, or whether e-cigarettes, by normalizing nicotine intake, by keeping people addicted, perhaps in different physical circumstances than they could use cigarettes, help maintain vulnerability to cigarettes or even serve as a gateway. And many other areas we're working, network impacts on obesity, interaction of gestational type 2, diabetes and obesity, TB and diabetes, and that link of substance abuse, HIV/AIDS, and suicide and domestic violence that I spoke about earlier. These are reflective of systems issues, issues where the behavior of the system as a whole transcends that of any one part of the system, or the sum of those elements, where there are systems effects, and within these areas, it can be very, very difficult to undertake two things. The first of them is to try to interpret, in a reliable basis, empirical observations, and specifically to understand the degree in which they are reflective of theorized underlying health-related processes. So if we have some hypotheses for underlying health-related processes in our population, we think, that e-cigarettes and cigarettes may be interacting in this type of fashion socially. They may be serving as a gateway, for example. It's hard to go directly from that hypothesis to empirical observation to see if indeed the empirical observations bear out the hypothesis. Often these empirical observations are rather distal and have only indirect relationship to these underlying processes. And we find ourselves trying to reason about, from these underlying processes, what will be the implied dynamics of the system if our hypotheses held? If these hypotheses concerning the interaction of cigarettes or e-cigarettes or concerning the ways in which gestational diabetes may be worsening the risk of type 2 diabetes in both mother and child, if those were the case, what would we expect to see from certain indicators, and so that we could try to line it up with empirical observations. And if we're relying on informal reasoning, figuring out what dynamics are implied by a theory is very, very difficult. Implied by a set of hypotheses which may span a number of different areas: mortality, initiation, cessation, relapse, etc. So we encounter challenges with complex systems and the need to explain what's going on. Is what's going on consistent with my hypotheses? Where is the situation likely to go next in the absence of intervention? What's driving these observed trends? Is a rising incidence within our population of STIs such as chlamydia? To what degree is that reflective of, in fact, if we have increasing amounts of reporting going on of chlamydia, to what degree is it reflective of underlying increase in the true incidence within the population? To what degree is it a success of reporting that we're increasingly identifying individuals who are infected with chlamydia earlier and earlier, and we are draining the swamp in terms of reducing the prevalence of undiagnosed individuals, and thereby contributing towards lowering the health burdens of chlamydia. What's driving these observed trends is sometimes not clear. We have many possible explanatory factors, and they interact and are entangled in complex ways. And trying to reason informally about the implied dynamics from that entangling is notoriously difficult. Sometimes it's difficult to see, as we indicated, is this a good or bad indication? But a second major need is that essential in public health is to address the need to intervene. We'd like to give secured guidance on where to best intervene, at what stage of the process to intervene, which target individuals or groups. To what degree do we focus in vaccination? Should we best focus on pregnant women? Focus on individuals in the healthcare system? Focus on children who exhibit very high rates of close contacts within schools? To what degree should we focus on vulnerable populations like elderly? How do I intervene? Should we close schools? Do there need to be corresponding measures for workplaces? To what degree should we look at routine broad-based immunization campaigns or focused outbreak response interventions? Often these are accompanied by questions, each of them. How soon will I expect to see effects? What will be the magnitude of those effects? How can we best scale up from this successful trial to the population as a whole, and to what degree will it scale up effectively? How can we make this implementation, say, of interventions focused on physical activity financially sustainable? for example, by coupling it with a tax on sugar-sweetened beverages. When it comes to understanding implications of interventions, we go beyond the challenges associated with how hypotheses involving underlying health-related processes might ripple through to yield outcomes and reasoning about the degree to which they're consistent with observations. And instead, we're dealing with this issue of to what degree interventions will bend these curves, will lower adverse health outcomes. And we're interested here in understanding the degree to which interventions' effects can be interpreted through empirical observations in a reliable fashion. We'd like to be able to undertake an intervention and learn from it in the most effective way possible. And often that's very challenging when these interventions have uncertain impacts, particularly portfolios of interventions interacting together on our implied dynamics. And again, reasoning informally about the impacts of interventions is fraught with difficulties, particularly when we're dealing with a diverse portfolio. At the same time, trying to judge the effects of interventions, of counterfactual interventions based on statistics from the past, is placing our confidence in the wrong area. We're changing, as statisticians will say, we're changing the nature of the data generating process from which those statistics have been derived. And if we try to use those past performance as an indicator of future outcomes, we could put ourselves at mercy of enormous misunderstandings. It's kind of like trying to drive looking at our back window. If we're dealing with counterfactual interventions, we need mechanisms that will allow us to reason about the effects collectively of those interventions as they entangle with underlying health-related processes in a more grounded sort of way. Now, this is the sphere that's this area that in recent decade or so has come to be known as system science, in other areas as complexity science, has come to try to address. In many ways, in reflection of a world where often the whole is greater than the sum of the parts, where we can't reduce systems simply to the sum or average of their pieces, such as with herd immunity and individual status with respect to natural history of infection. We need to grapple with these wholes. And system science, I view as kind of the science of the whole. It helps us deal with these entangled systems. And system science provides a variety of tools, foremost among them arguably being dynamic models, to help us visualize, understand, and reason about implications of understanding regarding underlying processes within the population. To reason about these underlying processes, how in an entangled way they imply certain behavior, which we can then compare and help cross-check our understanding against empirical data. So they help us understand the implications of underlying processes and test the consistency of those hypotheses, of those theories with empirical evidence, to do so more quickly and more robustly. An essential way in which system science does this, again, not the only way, but a central way, is through dynamic models. And these models weave together representations of our hypotheses concerning how diverse factors might interact. And by representing, in some sense, how things might work, by capturing these in a quantitative, precise form, hypotheses concerning the interaction of a bunch of factors, these models can help serve as thinking tools, laboratories for refining our thinking, and help us share assumptions with others. They can help take these hypotheses out of our head in a sort of inchoate form and put them in the clear light of day in an explicit, open, shared form that could be scrutinized by others, criticized, refined, and advanced. And often these models, reflective of this challenge, reflective of this goal of taking theories out of our heads and putting them into a form that's explicit, in a form that's easily shareable and easily understandable, increasingly these models are articulated in a rich visual fashion that, even if it couldn't be built by all members of a team, can be understood across broad teams, even those with no background in dynamic modeling. These diagrams are created with a software package AnyLogic, which we use in much of our teaching because of its more transparent nature of the models. And while the models are complex, there's a certain visual structure to them that can help those interpret them when first walked through them. So, for example, we can illustrate the stages a person might go through when engaging with the emergency department. We can look at stages associated with diabetic end-stage renal disease, where individuals might go back and forth between dialysis modalities. Some fall prey to earlier mortality. Others receive transplants and go through stages of risk, but are subject to a risk of graft failure. We could also classify the stages people are in terms of workup for transplant assessment, for example, and their presence on the waiting list or removal due to acute conditions. In other cases, our models might span through many types of different representations. Using these state charts, yes, but also continuous representation using stocks and flows, as is the norm in the technique known as system dynamics. So where we might have stocks associated with average glycemic intake and insulin levels and beta cell mass and function that track an individual status, both easily observable and latent with respect to diabetes and impaired glucose regulation over time. This work done with me only peripherally involved in the Sachs Institute by a former student of mine, looking at risk of suicide and progression of individuals through various stages of risk and engagement with the healthcare system, access to means, etc. These sort of models go by many names, which makes it very confusing to those new to the field. They go by the names mathematical models, causal models, agent-based models, system dynamics models, discrete event simulation models, compartmental models, models of the plumbing of the system or the physics of the system. We go by we use many names to describe these, and unfortunately in the broader literature, once you look across fields, there's a cacophony of names. But these models share a number of key elements. They differ in big ways in their details, but they share many basic themes. And the foremost one is they allow you to hypothesize causal structure of a system. The form of that hypothesis, it takes a different approach in traditional agent-based modeling versus with stocks and flows or with discrete event simulation. But the basic idea is you're representing hypotheses about the causal structure of a system, and having so done, you could then run the model forward to understand the logical implications of those hypotheses over time. Among other things, that allows you to compare the degree to which those hypotheses yield behavior consistent with empirical data. So these are mechanistic models. They depict this hypothesized causal structure, or what's sometimes called the physics of the system, and often they include substantial components that are latent. Just like modern statistics, Bayesian methods often include some latent factors. These models often include latent factors, often many of them. And by running the model, you're simulating the step-by-step evolution of the state of this microworld, of kind of this hypothesized system over time, how it evolves point to point. Within the model, we're specifying, given the current situation, how will the system be changing, using flows and system dynamics, using transitions within state charts, within classic agent-based modeling, etc. And then we ask, okay, what does that specification imply, that hypothesis as captured in those features, imply in terms of the evolution of the system over time? Now, critically, because we are hypothesizing explicitly a causal structure in the system, we can use these models legitimately to ask, what is the implication of that hypothesis for counterfactual situations, for novel portfolios of interventions, for example? First and foremost, I believe that these models should be thought of as learning tools, or, to use the phrase of my colleague Jeff McDonnell of Sydney, thinking prostheses. Prostheses are devices we use to complement our limitations in life. So if we break our foot, we'll use crutches and a boot, perhaps, to help us get around. It helps us achieve functional life despite our built-in limitations by the use of technology. And so it is with these models. These models can address an area where we as humans are very poor in our reasoning. Reasoning through, at a quantitative level, the impacts over time, the implications of a set of interactions depicted quantitatively in our model. Humans are exquisite at undertaking certain tasks, for example, visual recognition, but we're extremely poor, experiment after experiment has shown, in reasoning through consistently the behavior over time that's generated by even very simple nonlinear systems, or even simple dynamic systems. So these models help use computers to do that, and it turns out to be a task that computers are extremely good at, is helping us to take an explicit specification, causal specification, whether it's with state charts or the types of workflows we depict in discrete event simulation or stocks and flows, and they help us map out over time, okay, what will be the implications for behavior over time for the system as a whole. By helping us learn more, by helping us think through in this way the implications of our assumptions, of our explicit assumptions, say what behavior is generated by these assumptions, the simulation models help us learn more quickly. They help us learn more consistently, reliably, and rigorously what are the implications of our assumptions. They help us learn more quickly than we could if we were trying to reason them through in our head. And they help us learn more thoroughly than we could if we were just reasoning them through or in longhand prose. Extremely importantly, and in contrast to claims you'll sometimes hear that juxtapose or contrapose dynamic models on the one hand to empirical data and phrase them as alternative approaches, I would take quite the opposite view. That these sort of models, by allowing us to reason through the implications of our assumptions, they allow us to more quickly identify inconsistencies between the implications of those assumptions and what we see in empirical data. We can take empirical data and ask, to what degree does it jibe with what's coming out of these assumptions in a model? And that can help us more quickly falsify our hypotheses and more quickly identify the shortcomings of them and put in place better hypotheses. In short, help us learn more quickly. And we can put that empirical evidence to bear in much more complete and effective ways because within a model we're often depicting dynamics across multiple causal pathways, and this one model can help us line up and try to make sense of multiple lines of empirical evidence. So these models can help us more quickly identify gaps, shortcomings, omissions, blind spots within our hypotheses. But they can also help us better inform our choices by allowing us to evaluate counterfactual situations. They can allow us to better inform our understanding of what would the impact be of a portfolio of interventions. And finally, they can advance our understanding in terms of our current thinking on the matter in a way that gets captured in models and indeed our choice of data to collect. This general approach of trying something, of trying out this hypothesis or that one, and testing the degree to which they're consistent with empirical evidence, consistent with expert observation, is a reflection of a philosophy that, to the best of my knowledge, was first articulated in a scientific arena by Francis Bacon, where he wrote that truth will sooner come out of error than from confusion. That at first blush, that sounds like an ostentatious claim, an audacious claim at the least, that somehow by making errors you can be better off than by suspending your judgment and simply stepping back. But the idea here is something that's captured in a modern aphorism of fail early, fail often. Let's try something. Try one approach, try another, see which works, see which yields favorable results, and see which falls short. Put it another way, nothing ventured, nothing gained. By taking a model, building it, examining its assumptions, we sharpen our thinking in a way that can help us come back with a better set of hypotheses. So the idea here is, with a model, we have a systematic way of replacing confusion concerning underlying drivers by learning. We can go with a model and take these theorized understanding regarding health-related processes and map it forward to implied dynamics with the help of the model. The dynamic model directly will help us perform this mapping, which makes it far, far easier to then test to what degree these implied dynamics consistent with empirical observations concerning some of them. And if we do this in our head, we'll often end up in a world of confusion. With a model, this step can be very rapid and can allow us to refine our thinking regarding what's going on out there, what underlying processes are out there in a population. And even putting forward a poor model often advances our knowledge by helping us to spot inconsistencies between our assumptions and the evidence. So far from being crystal balls which shatter if they're off base, that offer no value, these models are learning tools. They're tools to help us spot more quickly inconsistencies between our hypotheses regarding underlying health-related behaviors, exposures, the ways in which environments shape behaviors, and empirical observations. They help us more quickly identify shortcomings in our theories so we can improve our theories to come in better accordance with the empirical observations. But that's not all. They have a critical role to play in terms of helping us to reason through about the behavior of counterfactuals, of interventions or intervention portfolios that have never taken place before. And again, without a dynamic model to help us understand how these interventions entangle with these already entangled set of health-related processes, instead of using just our intuitions and guesses and statistics gathered when it was subject to a different data generating process without an intervention, a model can help us understand, okay, How do these interventions causally end up impacting these underlying processes to affect the dynamics? And they can help us more quickly learn from the effects of that intervention. What's going wrong? Why aren't we seeing the effects that we would expect to see in terms of the gains? What's falling short? Model can help us understand the implications across many causal pathways, and coupled with the sort of evidence that will be coming from big data, can help us understand the gaps between the applied dynamics on the one hand the model implied dynamics, the dynamics that result from the model, and what we see via empirical observations across multiple pathways. This is very, very valuable within our arsenal. So the thesis of this work is that the advent of big data in health synergizes with and will fundamentally enable the sort of dynamic modeling we see from health policy, and critically will help us learn with much greater clarity as to where our interventions are falling short and how, coupled with models, we can best improve them. They'll help speed up this learning process associated with the model, where models are learning processes, to help us learn much more quickly through rich empirical evidence from the implications of the degree to which our assumptions are consistent with observations in the world, and will help us more quickly refine those assumptions, those hypotheses, so we can arrive at greater clarity, and we can arrive at intervention strategies that are more effective. Now, what is this big data? Well, big data is a term that personally I am not very fond of. I'm much more partial to data science, but it is a term, big data, that does have some meaning associated with it that I believe has bearing on health. I don't like definitions which focus on the underlying technologies, but rather it points to an underlying truth, a pattern as a cluster concept that is undeniable. There are larger and larger sources of data emerging that are different, not merely in degree, but in many cases in terms of qualitative features from traditional epidemiological data sources. This sort of digital epidemiology, as it's been called, raises some great opportunities and some challenges. Some of these include keyword search volumes, Twitter, the types of data that come from status updates on Facebook, or from environmental sensors in the world, embedded in the world around us by municipalities, from point of sale records involving not just pharmaceuticals but protective mechanisms such as bug spray. Yes, administrative data, but also electronic health records. Sequence data certainly qualifies. Voice audio data that might help in recognizing burden of mental health on the part of an individual, or stresses through detection of affect from audio. Records of incoming and outgoing calls, and from cell towers on sort of call patterns in a given region, and grouping behaviors implied by that. Health browsing behavior from individuals on their smartphones or on their tablets, and yes, still in some cases on their laptops. And very importantly, the types of sensors that are featured in full batteries on many consumer electronic devices, where we might pick up from a smartphone, for example, physical activity, proximity, location. Also, in many smartphones these days, aspects of environmental context, temperature, humidity, pressure, vehicular context in the form of magnetometers. It's shocking that the degree of the extent of the battery of sensors associated with electronic health devices. Now, taken on their own, these can be considered a kind of just a grab bag of different novel mechanisms, electronic mechanisms. But there's more to them than being electronic, more to them just that they're novel. There's really 4 key V's that best distinguish big data, a position that was first articulated, to my knowledge, by Google. So one is, and this is the one that captures the name big data, there's lots of evidence there, lots of data. But in my view, that's actually perhaps the least interesting characteristic. A more profound characteristic for its implications in the health arena is the fact that this data is high velocity. It's high temporal resolution data. It's data that comes in not with samples once a month or once a quarter, as might be secured by traditional self-reporting via phone or via paper instruments, but rather it's data that may come in several times a day, or in some cases every few minutes, in some cases many times a minute. Think the type of accelerometer data one might secure. So this is high temporal resolution data, and it's longitudinal at the level of a particular individual. So it's data streaming in about the evolution of that individual over time. But I think equally important, it's high variety. We have data about the same individual, so for the same period of time, not only about their physical activity from that accelerometer, but also about their location from GPS and Wi-Fi triangulation, or trilateration, I should say. We have data that might come in from their Bluetooth sensors, or Bluetooth low energy, that captures aspects of their social context, who they're with at the current time. We might get self-report as asked from that device, that phone or from a tablet via ecological momentary assessments that probes what they're doing right now or the motivation for that physical activity. And we might have something about their vehicular context that might help explain why there's such a long bout of sedentary behavior in the form of they're likely in a vehicle. So we have a variety of data, not just in general, but about these particular individuals whose longitudinal trajectory we can collect. And this variety is important for many reasons. Yes, it can address several different spheres of activity: social, physical location, physical activity and sedentary behavior, through cameras on the phones, nutrition intake, or weight as photographed from a weight scale or as measured via Bluetooth, etc. Yes, that's important, but also on a given question, such as are they in a vehicle, are they currently engaged in smoking, we can triangulate from several different sensors of sorts. So we can use their position, whether they're inside or outside is judged by GPS and Wi-Fi strength, to inform whether they're likely to be inside or outside. Through their physical activity and orientation as measured by gyroscope, we can get a sense that they're likely to be standing or sitting and pacing, as is quite frequent within use of cigarettes. Potentially for wearables that we see these days, we can get a sense of their heart rate and heart rate variability in a way that might clue us into whether they're smoking. We've done much of work with such wearables, and their promise is great in the smoking and other areas. In short, to arrive at if they're smoking right now, we can triangulate from many data sources. So it is with vehicular context as well. We can use magnetometers, we can use GPS speed, for example, presence or absence of Wi-Fi, availability of GPS, etc., to better pin down, are they likely in a vehicle, and if so, what type? Are they likely to be in a bus from its pattern of movement at certain intersections, etc.? Finally, veracity. And veracity, sort of the truth level of the data, or better, accuracy, is subject to misunderstanding. For some types of measurements of food as photographed by an on-phone camera, physical activity, as measured by accelerometer. We've known since the National Health and Nutrition Examination Survey, the NHANES 3 study in the state, just how glaringly different the insights from physical measures can be when compared with self-report. And physical measures can be much more reliable than self-reporting for a variety of areas. Nutrition intake, physical activity, when those physical measures, the appropriate types, but also things like social context, location. We found in some subpopulations big differences from what people self-report and where physical measures clearly suggest that they are who they're with. So we have less self-reporting bias, less recall bias, and we can also ask questions via self-reporting, via questionnaires triggered by context. That's much more proximate to health exposure. So we can ask them questions, for example, when they were exposed to a certain type of food environment or a certain physical built environment, a built environment that affects their physical activity. We can ask them questions about the effects of that. We can ask them questions when they are likely in an area with high mosquito density. Ask them about their experience, their exposure to mosquitoes or ticks recently for exposure to these risks. We can pop questions when they're in the vicinity of a fast food restaurant, for example, or when they're in a clinic. That helps lower recall bias. So within this sphere, just to give you a flavor and as a lead-in to some of our vignettes, there's a variety of additions to the health surveillance toolbox that leverage these new technologies to yield greater health insight. Health insights related to knowledge, attitudes, beliefs, and behaviors, but also exposures, health exposures to certain environments. And some of these provide very different sorts of information. Within this talk, just to give you a flavor, I'll talk about a number that we're working with, where I can speak from the authenticity of direct experience. Those include search monitoring, monitoring searching behavior on a geographic specific basis, use of social media, and use of smartphone based data collection tools. Search behavior is readily obtainable at a basic level via Google Trends, for example, but we can do much better with that with so-called application programming interfaces. Programmatic have programs that query for certain types of data. We can get volumes of search data that provide some indication of interest, in some cases concerns, regarding certain factors within a region. And Google Correlate, correlate.google.com, can help you identify particular searches that provide responsive information that aligns with certain epidemiological trends. And if you upload a time series, can help you identify responsive search queries that seem to mirror those trends. And there's a massive volume of these searches taking place worldwide as we speak, with an estimated over 60,000 or so of these searches per second taking place worldwide. Those are searches per second in the tens of thousands. These are aggregate quantities. They don't alert us in terms of the data that's readily available from these services. They don't allow us information about individual behavior, but they can give us a sense of important trends and important changes. This from searches related to on whooping cough in Australia, which showed a pronounced difference over time between searches related to whooping cough before and after a particular incident, the tragic case of baby Riley, who passed away from whooping cough needlessly given the availability of vaccination. And you can see it led to a substantial and in fact quite prolonged over a multi-year basis response in the the occurrence of people searching behavior, presumably somewhat reflective of some concerns concerning child health, etc. Beyond that, there's opportunities to engage in monitoring of social media. One which I'll feature here is Twitter. Twitter has a very high level of participation worldwide, with over 300 million users worldwide, and active users within the states form a large group. Twitter is not a channel used by as widely as Facebook, but it is a channel used by a lot of key opinion leaders. It's a channel which plays an important role in shaping knowledge, attitudes, beliefs in many cases. And it's very high volume and high velocity. One gets often many tweets a day from a given individual, and worldwide we're dealing with more than 10,000 tweets per second worldwide in bursty periods. We have a large and established program of tweet harvesting for a number of jurisdictions that archives tweets across certain geographies for subsequent retrospective use and for baselining information. And these tweet archives can be accumulated year after year for giving you a sense of changes in patterns. In contrast to searching, tweet behavior, one can distinguish individuals who originate a tweet, who retweet, expressing interest, and we can follow the behavior at an individual level as well as at a more aggregate level. And one can perform there are tweets that are geotagged. There are a small subset tagged explicitly with GPS locations, but there's a much larger number that can be geo-inferenced, where we can find out likely location based on the user's stated location, not the location tagged directly onto the tag, but the user's stated location, or the location but not GPS coordinates on the tweet. And more sophisticated schemes have been explored as well, such as doing inference based on friendship networks, etc. We can filter tweets by content, geography, time, and in some cases sentiment, although the built-in abilities to do that on Twitter are very crude. And we can secure this data in a streamed fashion. Twitter streaming provides just a 1% or so sample of tweets, but we can use pseudo streaming to get actually a very large, vastly larger set of tweets in kind of a pseudo streaming fashion. We do so every 15 minutes, for example, for our work, and we can do retrospective analysis that can be quite insightful, where we relate these to past issues. And we can look at changes over time in response, for example, to interventions. For example, interventions related to a community that's a small community that suffered many recent suicides and is dealing with a high burden of distress from that, looking at tweet behavior. The final sort of little comments on elements of the spectrum, it relates to this far end of the spectrum, where we have finer insights than we did with Twitter or search. We have higher recruitment challenges in many cases, but we have vastly, almost incomparably greater flexibility and insights that can result from the data streaming in. This is work that we've had going on at some level since 2009, 2010, since the flu pandemic, and it spanned 3 major generations of work. The current system, Ethica, involves several components. Very importantly, there's an app running on Android and iPhones that can be used to collect data from those devices, ask asking questions, sensor data, etc. It can also tap into wearables nearby the device and can capture browsing behavior as well. This system runs on participant smartphones in most cases. For certain low-income groups, say homeless individuals, we may offer them a phone to carry. And because people are carrying it on their own phones, there's this internal incentive to carry it and to keep the device charged. We're not asking them to carry around a paperweight in addition to their normal habits. And they're often on the devices a great deal for searching behavior, for interaction around media, etc. There's all these studies go through ethics and informed consent, and from the device, in some cases in a very tiered way that allows people to opt out of particular sensors. We can collect diverse sensor modalities, data related to proximity, data related to location, data related to social context, data related to people's physical activity, data related to their environment when it's available, browsing behavior, wearable use, wearable data, etc. The questionnaires, however, provide an extremely important additional feature, and we have the ability on the system both for proactive self-reporting via buttons on the interface, as well as to pop questions that can be contextually triggered. So when a person is in the presence of a certain set of other people, say a person is known to be a smoker, nearby them, we can ask questions. We can ask questions after a long bout, for example, of sedentary behavior. We'd have the flexibility to do that, or to ask questions based when they're near a fast food restaurant or have been recently. So we can ask these questions, or they can be using classic ecological momentary assessment. They could be sampled at random times during the day. There's little or no programming required on this system. For many of the studies, a great number of the studies can just basically roll out a new study without programming. You define graphically the questionnaires you're interested in asking, associate with that the buttons. You can simply check boxes about which sensors you'd like to collect data on, whether you'd like to collect it on, let's say, GPS or Bluetooth for proximity, and accelerometer, etc. And you can then deploy a study. Now, the system which we've used on the smartphones has been configured over the years to collect data from weight scales, from smartwatches, from social media, several types of smartwatches, from communicational behavior in addition to the above. But that's just one part of the system. There's also a broader system that can be used on the website to inspect the results, to browse the related behavior, to perform a regular reporting, say on adherence / what used to be called compliance of individuals, to monitor how many people are answering, for example, their questionnaires, how many things are they volunteering with the buttons. We can look at patterns using heat maps, where they've been, where they've answered the questions, what their responses have been. Take a look at the photos and indeed the audio recordings that they've submitted, etc. And we've applied the system to a wide variety of different collaborations, everything from e-cigarettes and cigarettes and their interaction to foodborne illness, where Cheryl Waldner to work as part of a CDC-funded randomized control trial for influenza, together with Alice Iniello and Eric Vols, and just getting into some applications in HIV and intravenous drug use, quite a bit on the mental health side, some in food environments, etc. A foremost goal of this system, as one can imagine, is security, privacy, and confidentiality. And in all cases, in all studies, we have a snooze option to stop data recording at any time as requested by the participant. In many studies, there's also the ability to opt out of certain types of data recording. And people can turn off their GPS on their phone at the least, but in some studies, it's a very tiered system that we allow, and even have opt-in for some of our studies for the types of sensor data. There's very strong on-device encryption, 2 levels of encryption with our original system, and I believe that's in place for our latest version, the Ethica system as well. Secure transmission via secure HTTPS and encrypted channels. Censoring of potentially identifying information, and for many studies we've run, and optional restrictions on monitoring pools of Bluetooth connections, so we can only look at those within the study. And then there's an informed consent process that is sometimes tiered. So those are some characteristics of big data. Before that, we talked about system science and dynamic modeling. How do these come together? Well, it turns out that they come together in a variety of ways. One of the ways, as might be anticipated if you've done some work in the system science areas, is parameter estimation. In many cases, the types of data collected via these novel technologies, big data as it were, can provide an excellent source of parameter estimates for a model. Estimates that relate to probability of engaging in certain types of health behaviors or exposures, the probability of presenting for care given certain symptoms, etc. But in other cases, the relationship is actually not one of parameterization. We're not actually directly taking the data collected and placing it into a model. Rather, we're calibrating a model against the data. And the idea here is that the data we collect with the phones in some case isn't reflective of any one thing. Rather, it's a reflection of an entangled series of factors that contribute to it. So, for example, the frequency with which an individual is using e-cigarettes over time, or their social network, and the degree to which their social network includes other cigarette or e-cigarette users. For many models, we wouldn't put those in directly as a parameter in the model. Rather, we'd expect a model to be able to generate that social network and its characteristics, the degree to which it includes other individuals using same sorts of electronic cigarettes or tobacco use modalities. So here we use the collected data, perhaps collected across many different pathways, as collected by these electronic data sources, smartphones, Twitter behavior, what have you, in Twitter exposures. We try to match those against model expectations. This is particularly key for an intervention where, for example, we're trying to make sure that before simulating an intervention, the model matches the baseline behavior that we observe from the world across multiple interventions. So when the intervention takes place, we can examine the outcomes across those different pathways, those different causal pathways, to see what's changed. And so in these cases, we're calibrating a model to observe data, to examine the degree to which it is consistent with the data, and to help us tune aspects of the model that we have measured less centrally. In other cases, for these cases, we can learn very effectively from the collected data together with the model's expectations. We can learn from the intervention much more effectively. We can learn where do we anticipate correctly what would take place, where do we fall short. We can work to improve the model, and most importantly, we can work to improve the intervention. Finally, we can, in many cases, integrate filtering systems, which basically use this incoming data to recurrently correct model estimates of sort of the current situation, correct that model, sort of clue it in, reground it in the current situation, and use that model to project forward. Now, given the timing, I only have time to give very brief glances here at various projects. For example, in the E.D. Waits project, we have a number of models spanning major hospitals, some representation of community options, an area of great investment in coming months and years. And we have some ad hoc models. And the models have been used extensively to provide advice to our Ministry of Health, but increasingly we seek to inform them with the types of big data that we're gathering, whether it's search data to look at drivers for visitation patterns, whether it's looking at the impact of mobility in the context of interdisciplinary rounding and patient outcomes. Use smartphones to record people's movement there, and we can use it to capture aspects of interaction with with informal and formal caregivers. But much of the interest of late is using these sorts of devices for community care dynamics to capture fingerprints of function for individuals' contact with informal caregivers and home care, to understand the degrees in which patients' needs are being met, and to capture aspects of care seeking and informal caregiving that might otherwise not be readily available. In other cases, and this is work with, the previous work was with Jenny Bazran, Yuan Tian, the Health Quality Council, Ministry of Health, and increasingly with the Skipper project. This next one is on the area of foodborne illness, and this is work conducted thoroughly with my my tremendous colleague Cheryl Waldner, incredibly knowledgeable on the foodborne illness area, and just a source, a wealth of sort of understanding and good guidance in the area of foodborne illness. And here we're dealing with a model. It's a little bit more stylized, and within the model, we've had a variety of factors represented related to reporting of related to foodborne illness. And one of the key realizations here is that within the current context, the cases reported to public health of foodborne illness are, as Cheryl puts it, not merely the tip of the iceberg, but the spike on the tip of the iceberg, the sort of small needle of ice. It might be something like 0.2%, is I think one estimate I've heard, of all cases of foodborne illness are reported to public health. And yet, one posits very clearly that there's large amounts of exposure to contaminated food going on, yielding subclinical illnesses, and in some cases, clinical illnesses that don't get reported. And one of the problems here is it's through those reporting mechanisms that outbreaks can be declared and that outbreak investigation can take place to shut down contaminated vendors. So to the degree that we're missing out on the large set of number of cases which are not reported, we're missing out an opportunity to more quickly trigger outbreak investigations and more quickly shut down vendors that have real problems. So we might have a dynamic model. We do have a dynamic model here where we have consumers in a number of different states, those exposed to illness, presenting for care versus subclinical illness or healthy. We have individuals who are exposed over time to food seeking in safe or contaminated venues. and we have a representation of inspector behavior that has them alternating between routine inspection work, outbreak investigation, where outbreak investigation is in response to a triggered recognition now of a likely outbreak. Now, one of the challenges is that in building a model like this, as we did several years back, there's some real challenges in terms of estimating some parameters, whether it's aspects of risk awareness on the part of individuals, or the degree of food seeking from different subpopulations at vendors, the degree to which there's good recall by individuals, or to which there's a high burden of subclinical illnesses. These are hard to secure information on via traditional mechanisms. And while we can engage in self-reporting with traditional instruments, say via a pen and paper or random digit dialing or more focused calls, often it's subject to great participant burden, difficulty in recalling the cases of food-seeking behavior, recalling certain symptoms that are subclinical sometime after it. And accuracy of recall, I would highlight as something that's particularly big vulnerability, because in some cases we're depending on people to remember back not just 1 week, but several weeks earlier, where they ate food and what they ate at those venues. I'd like to bring us back to this recollection of the reflection of dynamic models as thinking tools or thinking prostheses. And a major barrier for those models is the fact that getting information on factors such as this is challenging. It's very difficult in getting reliable behavior. So to supplement that sort of model, we've made use of smartphone-based mechanisms. This provides a glimpse of the work that we did, and Cheryl took the lead on this in terms of putting together a system to record this. This is in the Ethica system. You can see this is the Android version. There's a separate iPhone interface. And within this particular study, there's 2 buttons featured. One that allows an individual to directly report that they're feeling sick, and if they do, they're asked if they sought care for it. Do they suspect the illness might be related to consumption of alcohol? This was focused, in this case, on a student population, and the nature of their complaints that might allow us to identify likelihood to which it's plausibly foodborne illness. And over the course of this 3-month study, this was a 3-month study where individuals carried the app on their devices. We had a modest number of cases of illness reported with this button, with varying from 0 as the most common number up to 7. There was another button where they could report eating, and here they would be asked to take a photo. They could explain the nature of the food and ask about the source of the food. And this is an example of via the website, although this is an earlier, somewhat cruder version of the website, where we could browse the submissions from particular individuals. You noticed it indicates when they answered it, how soon. In fact, each question it's recorded for when they answered that particular question, so we can check dwell times. Also are marked, of course, are where they answered this question via GPS and other sensor data about context. But it does show indication of the food and in this case the audio by which they reported what it was. And just to give you a sense, when it came to reporting food, the individuals were remarkably, over the course of 90 days, remarkably fulsome in their
their reports. As you could see, the sort of median number of reports for this study was somewhere around here, 80 to 90. So it's about 70 to 80 number of reports. This is a histogram. So the y-axis here is counts. The x-axis is then the bin showing the number of reports that into which their responses fell. So if someone submitted between 80 and 90 reports, they'd go into this bin. And that was around the median. It fell somewhere between 70 and 80 reports over the course of 90 days, so almost one a day. Some individuals reported hundreds. Comparatively few reported, were highly negligent by contrast. To give you a sense of the type of data in terms of its longitudinal character, this gives a sense of three different trajectories, where we're looking, for example, at with individual 1, cases where each of these green vertical bars, where they reported eating at home, in orange, where they reported eating outside of home, and in red, where they reported feeling ill, using that button. And you can see these three individuals each reported some illness. We could look at its relationship to these cases of food seeking, and we could ask, using recurrent events analysis or some other form, the degree to which eating at a restaurant, for example, is associated with adverse outcomes. Ecological momentary assessments here could be used to double check their proactive self-reporting, and we engaged in a great deal of that. So we asked them to respond to these EMAs that would cross-check the consistency of the thoroughness of their reporting, both on eating and sickness. Once again, this is a photo of the interface from Android, I believe. And here you could see that people were remarkably, as is the case for actually some of our other studies, certainly not all, but remarkably good at reporting. So most individuals reported 85 or over percent here, certainly, with the mode being between 90 and 95% of the questions answered on those questionnaires answered on those studies. So this too is a histogram, and this is the fraction of the total participant count that answered that. The reporting interface allows us to sort of browse cases of these reports. And of course, because these reports are cross-linked with sensor data, we can map out, for example, where people reported eating non-home cooked food around town, and we can ask where did they report eating non-home cooked food within 24 hours before a reported case of highly specific illness, for example. Illness is plausibly food-related. Now, I'd like to indicate some ways in which this intersects with our model. So you'll recall within our model, we had trouble estimating certain factors. We did have, for example, traditional data sources on what cases would be reported to public health, and one might get through traditional mechanisms for a given context records of contaminated vendors that have been found, as might be published by departments of public health or ministries of health, and then occurrence of warmer weather. But when we come to big data, the sort of data collected via these phones, as we've just been talking about, there's a wide variety of other types of data to which we enjoy recourse. Those include data related to risk awareness, risk perception, food seeking at vendors. We can look at where people are going and visiting vendors over time. We can actually assess, and Cheryl did a tremendous amount of detailed work on this, accuracy of recall. we can look at subclinical and clinical illnesses. So for parameter estimation, for example, we could look at those who reported illness exposure, how many of them, presented or reported clinical or subclinical illnesses, just to be very clear about where that could be found. You may recall that we asked people when they reported illness, did they consult a healthcare professional with regards to that illness? We can use those fractions that did to sort of shape, how many of those individuals presented with clinical illness. We could look at how long the illness is by asking them questions about that. We could ask, for example, how frequently they're visiting certain venues, how broad a set of venues visited by a given person is. These are very difficult things to collect information on reliably using traditional instruments. And those just provide, a few examples of parameter variation. I've listed some others of parameter estimation as well. In addition to this, we examined ways in which a model such as this could be used to, together with smartphone-based data collection, such as via this device, to actually serve as an intervention. And so we sought to ask, okay, if we had people within the population carrying this app for just a small fraction of the population, say 4%, how would it lower the burden of clinical illness or subclinical illness? To what degree would it lower the burden of numbers of cases developing clinical symptoms, for example? And we found that actually with a very small fraction of the population carrying the app and the results being used to trigger outbreak investigations rather than purely traditional clinical reports, we found that we could reduce the burden of subclinical illness by a factor of more than 2, and we could further reduce the burden of clinical illness. Another key advantage, though, here of these sorts of tools is by helping us learn more quickly from our interventions. Remember the idea of dynamic models as thinking tools. Here, we're seeking to accelerate our learning from interventions by distinguishing causal pathways that are and are not being successfully nudged by an intervention. Using the types of data collected via the phones, and particularly complementing the types of understanding that comes from models, we can zero in on which pathways are the major drivers for outcomes that we see, which pathways were successfully altered by an intervention, which were not. Did we improve physical activity but not change sedentary behavior? Is it possible we worsen sedentary behavior, for example, through this intervention design? Maybe we successfully enhance physical activity but not nutritional intake. We could start to look at reasons for intervention success, and using a model together with the sorts of data, we could test hypotheses to what degree the types of intervention outcomes that we see are working across purposes, or where effects are being felt in the pathways but not yet in the outcome, and assessing the degree to which there are bleed-through effects from intervention to control group. So, for example, if we, as in some other work, we were using phones to try to examine the impacts of moves from mixed income environments to outcomes such as obesity levels, pro-criminal involvement, and likelihood of high school graduation. If you're relying on traditional instruments, it might be hard to distinguish between many hypotheses as to why this housing voucher program, this move to a mixed income environment, has yielded the outcomes. For example, in the Moving to Opportunity program, obesity levels were successfully lowered or improved for high school girls, but not for high school boys. But there's many hypotheses that circulated for why this might be. Perhaps, for example, this was because of higher perceived safety of the neighborhood. The girls were out walking and enjoying the neighborhood more, and because they had fewer safety concerns, and that led to an increase in moderate vigorous physical activity and thereby lowered BMI and obesity levels. In other cases, it might be hypothesized the availability of recreational space was greater, more ball courts, more playgrounds, etc., and that led the girls to engage in higher levels of recreation within these facilities, which in turn lowered moderate vigorous physical activity, improved BMI and obesity profiles. In other cases, it may be that one could argue that it's improved walkability. Other researchers argued maybe it's because these individuals spent more time at home. They had fewer friends in the new neighborhood. The girls spent more time at home, and they were exposed to a somewhat healthier diet than what they would be exposed to in fast food restaurants, etc., and that lowered BMI levels. In other cases, it might be it's an impact of aspects of school quality that led to some of the outcomes, or indeed researchers hypothesizing that moving from a food desert to an area with a healthier food environment, perhaps it's through the availability of healthier foods, fresh fruits and vegetables, produce sections in the grocery stores rather than relying on convenience stores for much of the intake. That led to a healthier diet and lowered BMI. These things are hard to check through reliably through self-report using traditional instruments issued once a quarter, asking people where they're buying food, to what degree they've used playgrounds and ball courts, the degree to which they've been actually out and about on sidewalks or in those courts. These are things that are challenging to measure. But with smartphones, collecting data, and with a model anticipating what the outcomes might be, and with smartphones collecting the data on what occurred pre and post intervention, you can actually start to resolve changes at particular levels of pathways. And key, we can compare those changes to what we expected through a model, and use that to improve our model, but improve our understanding of our hypotheses of what's going on, and perhaps most importantly, improve, using this collected data from the model and from the smartphones, improve our recommendations for interventions so we can arrive at more responsive interventions. Interventions whose needed changes we can often identify through seeing which pathways were successfully nudged and which, perhaps sedentary behavior, were not nudged, to arrive at a better intervention, and then test that hypothesized better intervention, different possible interventions, against our improved model, where we've improved our model by seeing what really changed compared to what the model thought would change, and use that to arrive at a better intervention strategy yet. In other work, such as this work with Kelvin Choi, intramural researcher, great collaborator at the NIH, and Erica Penz here at Saskatoon Health Region, and through much of our time here at the U of S, we've used dynamic modeling to characterize behavior of individuals over time with respect to tobacco use, and indeed with respect to uses of particular modalities and nicotine exposure addictions more recently, and work with just starting up with Public Health Agency of Canada as well. And we can use mobile technologies, and we have used it extensively, or with our work with Erica Penz, to understand the microbehavior of product use, procurement behavior, product switching, and interactions of the above with knowledge, attitudes, and beliefs. And to recognize these microbehavior patterns that we didn't realize otherwise were the case. For example, long periods of e-cigarette use compared with the comparatively short periods associated with tobacco use. We've also got some very exciting work that looking very successful in recognizing likely occurrences of cigarette and e-cigarette use. Just to give you a sense of this, this is an individual's exposures over time, use over time with vaping and smoking. Capture where it's occurring, what times of day it's occurring. Their self-reports on the degree to which their use is taking place in different types of social milieus, for the different types of products, the nicotine levels they're reporting for the e-cigarettes, which e-cigarette liquid, and the source of e-cigarettes, what prompted them to smoke, the kind of, as reported, proximal impetus, and to use an e-cigarette. Notably, quite different graphs here associated with these different outcomes. So within this case, we're using e-cigarettes and cigarettes to get a more fulsome sort of comparison between within the ecology of tobacco and nicotine use, to gain an understanding of the ways in which that interplays with possible interventions to lower the burdens of the use of those products. I could go on, describe some of our work in HIV, AIDS, and the use of mobile technologies, particularly with at-risk populations such as homeless individuals, and to classify patients into categories. This is work with Alex Wong, very exciting, with the Regina Capel Health Region, a leader in sort of his vision for HIV management within this context, and can inform things at both the public health and at the clinical level. And other work going on with ideation and mental health with a variety of partners, including Rudy Bowen here at University of Saskatchewan, the Sax Institute with Joe Atkinson, Andrew Page, University of Western Sydney, and Jeff McDonald, coupling models with mobile technologies to allow for capturing and understanding of mental health. I think, however, in light of the time, I'm going to draw this report to a close. I had to skip through a bunch of vignettes. Where we're going with this is population observatories. We have some very, very exciting work going on with some of our partners here in Canada at the provincial level, forward thinkers looking at the potential for broader cohorts, tracking individuals, following people on our smartphone, web, and exposure to Twitter messages and web content, all going through consent, and rolling out content over time to this existing cohort on various topical matters, perhaps in the light of burden for foodborne illness, questions related to that. In other cases, questions related to perhaps tick-borne illness or vector-borne illness in the form of West Nile, and other areas where we've done work with smartphones. Rollout of content with respect to mental health during the holiday seasons, where some of the burdens are felt most acutely, or content related to outbreaks and contact patterns as related to measles. One of the areas that we're most keen is this idea of holding data in escrow for emergency use, where someone might allow for collection that's sort of government contingent on the fact that it's only used in the case of a designated outbreak or emergency, and where in that event their data, perhaps on contact patterns or establishment visitation, care seeking, knowledge, attitudes, and beliefs, could be used to shape policy as informed by models in those events, and can help appreciate patterns of behavior for quick reaction by the government, suddenly opening up not just data going forward, but data retrospectively that might help us understand where's this measles outbreak coming from, or this pertussis burden that we see in certain sub-communities, but guaranteeing the privacy of individuals who otherwise aren't comfortable sharing their data. In short, there's a natural synergy here between electronically sourced data, sorts of big data we have, and dynamic models. These sorts of models can help make sense of this data for policy, link it up with interventions and intervention outcomes, can help us relate what we pick up on the phones to underlying hypotheses for what's going on out there in terms of behavioral drivers as represented in the models. We can check the degree to which it jibes, not just across one causal pathway, but many pathways with the sensor data. Models can also help us critically fill in an understanding of how those patterns might be expected to change with counterfactuals so that we could plot better interventions. Interventions, yes, that leverage what we have observed in the current data generating regime from the smartphone data, but lets us anticipate how it might change going forward. And then, having launched an intervention, have us compare those expected results with what we actually see from the intervention. Again, profoundly improving our ability to learn from our interventions and our ability to learn from both models and the empirical data. So these types of models can be used for filtering sensor data. I didn't have a chance to talk about this. We have very exciting work going on with particle filtering and particle MCMC. These are techniques that can be used to look forward, as we've done for many, many conditions with particle filtering. Keep the model constantly regrounded with the latest evidence coming in, and yet look forward to evaluate interventions. At the same time, the sorts of sensor data can ground these models on high-velocity longitudinal data, can help us really ground our understanding of health behavior and cross-check model predictions to more quickly spot inconsistencies, more quickly spot shortcomings and omissions, but also inaccuracies in the model. They can provide databases, these sorts of novel data sources for model parameterization and calibration. And they can help stimulate new dynamic hypotheses and cross-check model anticipated outcomes. Empirically grounded models of the sort that we're increasingly building, models that posit detailed understanding of human health behavior, exposures, knowledge, attitudes, and beliefs, behavior change. They really require data to pin them down in a way that can allow us to examine the quantitative impacts between the different interventions. Fortunately, we live in an era where electronically captured data is increasingly ubiquitous, spanning from social media data to data on individuals through things like accelerometers, GPS, and Wi-Fi measured location indoors and outdoors, social context. Commodity sensor-bearing devices, like our day-to-day smartphones, tablets, wearables, can serve as a dual use as versatile sensor, EMA, and crowdsourcing platforms, in addition to offering their traditional value to those who carry them. And diverse communication mechanisms, GPS, Wi-Fi, and Bluetooth, etc., can help us derive context. Together with models, dynamic models, these sorts, and in fact a whole hierarchy of models such as machine learning models that we've built to be responsive to these challenges, sensor data can offer really significant and complementary health insights. And cross-link sensor-based in EMA data can offer tremendous potentials to complement and sharpen our dynamic modeling. And a key use of this data for social and health policies to learn more quickly, more reliably from interventions, whether successful or not, so that we can arrive at new intervention strategies informed both by models, but yes, critically by this sort of big data to allow us to achieve health outcomes responsive to the needs and burdens of our existing populations. I'd like to finish this talk by providing my sincere gratitude for a variety of funders, including NIH, the Network for Inequality, Complexity, and Health, American Legacy Foundation, now Truth Initiative, Royal University Hospital, Saskatchewan Health Research Foundation, our collaborators at Alberta Health Services, and ministries of health across multiple projects. I'd like to provide my sincere thanks to Mohammed Hashemian and other staff at Ethica Corporation for their superb work advancing the Ethica system, which grew out of our IEPI work, and my collaborators Cheryl Waldner, Kevin Stanley, Jushin Liu, and our work with as well Kelvin Choi and others, Ron Wall at Public Health Agency of Canada, and a wide variety of students and trainees, particularly Winchell Chen, Narja Shujati, Kurt Kruger, and a growing amount to Aiden Tehui and to Anahita Safa. Thank you so much, and I hope you found this lecture of interest. I'll hope to post others which expand on additional components of our work.